Hi, everyone. Give us just 1 second.
Oh, I see Chris. No, I was just with Chris and for a research meeting.
Nice.
Hey,
Hey,
Chris.
Dr. Takayama, good to see
Hey,
you.
hey, good to see you. I'm sorry that I'm late because now after the meeting, Ed and I always chat for a while and talk about research and other stuff. Sorry, that's why I'm late.
No problem.
Yeah.
All right. I think we can get started. Good morning, everyone, and thank you very much for joining us for another Aorta Chat interview as part of our Aortic Disease Awareness Month campaign. My name is Adam Ahmed. I'm a fourth-year student at CUNY, and today we are very lucky to host Dr. Hiroo Takayama with us. Dr. Takayama is the Chief of Adult Cardiac Surgery at the Columbia University Irving Medical Center, where he also serves as their Director of the Aortic Surgery Program and Co-Director of the Marfan Clinic. Dr. Takayama has over 20 years of experience managing complex cardiovascular and aortic disease and regularly performs over 300 operations a year while training several generations of residents and fellows. Dr. Takayama, thank you very much for taking time out of your exceptionally busy schedule to talk with us. How are you today?
Good. How are you? And thank you very much for inviting me. And again, I'm sorry that I'm late, but let's go get started.
Problem at all. So to start off, could you tell us please a little bit about your inspirations for pursuing a career in cardiac surgery and then subspecializing within aortic surgery?
Yeah, thank you. So though I was fascinated with the heart surgery from the time of med school. No, I was in Tokyo and just doing clinical rotation. And I wasn't particularly an enthusiastic student, no, doing the rotation, minimum amount of tasks, getting bad grades. But during the rotation for heart surgery, one of the professors allowed me to touch the heart, and that was very impressive. And that's how I decided to become a heart surgeon. And since then, perhaps because I don't think carefully or deeply, no, I was fixated with a goal of becoming a good heart surgeon. And that led me to pursue a career in the US, leaving Japan for a better training. Then after the training, I stayed in New York, Columbia. After becoming a heart surgeon, though, my laser focus has been always try to be a better surgeon tomorrow. And aortic surgery became a thing for me for two reasons. One, it is technically a very challenging operation encompassing beyond the heart and sometimes all the way to the iliacs. And second, it happened to be by the way, I was interested in doing any kinds of heart surgeries from the heart failure, CABG, valve, and so forth. But the aortic position became available to me. Perhaps I was doing everything, but nonetheless, after that, I decided to focus more on the aortic.
Wonderful. Thank you for taking us through that. And now, in your experiences managing aortic disease, I know that you and your partners have embraced multidisciplinary collaboration at the Aortic Center at Columbia. Could you tell us a little bit about the importance of bringing multiple specialties together to manage these complex patients?
Very good question. I believe the surgeons have to continue to learn, and that's how we get better. That's how also we could potentially contribute to a better patient care beyond yourself tomorrow. The aorta is an interesting organ. Of course, multidisciplinary approach is being recommended and implemented in every single aspect of medicine and every single subspecialties, specialty of heart surgery. Aorta is no exception, and perhaps even more since the aorta perfuses so many organs. So realizing that and or riding on that momentum, in 2017, we established a Columbia Aortic Center, and that with a key partnership with vascular surgery. Coincidentally, vascular surgery was recruiting a new chief, Dr. Virendra Patel. and he and I had the same goal, which is to be able to provide the highest quality care, and also explore cutting edge technologies to improve the aortic care. So with that goal in mind, we established this aortic center. And since then, our partnership has been expanding to other specialties like radiology, cardiology, primary care, and we have a monthly meeting, and additionally, combined clinics. All of that has been wonderful for my personally to learn from other people, and I strongly believe that it is helping our patient care.
Absolutely, and also advancing research for other centers. We had Dr. Chung on the line with us last week, and we discussed your aortic surveillance program and some of the indications for that. We were wondering, something we didn't touch on last week was the role of genetic screening in managing aortic disease. We were wondering, well, what groups of patients that you see would you recommend they get genetic screening, and how does that guide your treatment?
Genetic screening, no, it's thanks for bringing that up. I think that's a very important thing to do, and of course, genetic specialists should be a part of the aortic team. So for us, genetic screening, by the way, genetic screening can be done nowadays in pretty handy fashion. Some of the commercial companies sell kits. So you can partner with those companies, and what they do is they send patients a cup to speed up the saliva, and that saliva can be tested for the set of genes for known to be related to aortic aneurysms. I personally believe the service should be beyond that kind of like no yes or no for the genetic result, looking at the result of the genes. So for us, we partner with our genetic experts. Colombia has a genetic clinic. So we refer all the patients younger than 70 to our genetic clinic. So they do a formal interview, looking at the family history and other characteristics known to be related to the hereditary thoracic aortic disease. And then they do this genetic testing, and then they interpret the result in the context of other backgrounds of the patient. I think that will give our patients have high appreciation of that process, since they get full understanding of the genetic panel, as well as its relevance to the family, and the patients get to ask very sophisticated questions. Now, how does it impact to patient care? No, I'm going to avoid talking about the knowledge thing here. You can read the guideline. By the way, 2022 aneurysm guideline by the ACC, it's a very written guideline, and all of us can read it and learn the most contemporary knowledge by reading it. So I'm not going to talk about knowledge. By the way, I don't remember them either. But nonetheless, the genetic results of the genetic testing will influence the surgical strategy, in the sense that certain genes are known to indicate higher risk. So if you are positive, if your patient is positive for certain genes, we lower the surgical threshold of the diameter, as you all know. Now, I would expand this conversation and challenge all of you. I think this is, genetic testing is critically important. No, for nowadays, for the practice as of 2024, it is important because it changes the threshold for surgery. By the way, threshold of surgery, I think, is currently determined by the diameter, heavily determined by the diameter. And genetic testing will have some allow us to modify that. But if we think about the aortic disease, no, aortic surgery is elective aortic surgery is performed to prevent aortic emergencies, and the aortic emergencies happens because the aorta wall of the aorta breaks, right? And we know large aortas have a weaker aortic wall. Also, maybe the tensile strength of the aortic, along the aortic wall is more. Therefore, they're prone to rupture or dissect. But is it we all know that diameter alone is not a perfect indicator to assess individual risk of aortic emergencies. No, if you consider a scenario where somebody's aorta is made of iron pipe, even your aorta could be let's say 10 centimeter, it will not break for sure. So the integrity of the aortic wall is critically important when thinking about the indication of this prophylactic operation. We just however, we just don't have a way to assess that at this moment. Genetic testing is one of the ways to look into the integrity of the aortic wall in my mind, because certain patients with certain genes, they are known to know the genes are known to be related to the aortic emergencies, and that is an evidence that those people with abnormal genes, genes, abnormality in those genes, they have weak wall. And that's what we want to know. So for young people like yourself, I would love you to study for us to understand, to enhance our understanding of the integrity of the aortic wall. Sorry, I talked too much.
No, no, definitely. And I think it's definitely an exciting time for us to be entering the field, and as we're kind of discovering these new genes and genetic predispositions to these aortic syndromes, it's good for us to hear about it and kind of familiarize ourselves. I wanted to ask you a little bit about, I know you were instrumental in helping to start the New York Aortic Consortium as a means of bringing together some of the leading specialists in the city. I was wondering if you could talk a little bit about your experiences with the group and what this means for patients.
Um, I personally, again, loves learning from others. Maybe because I don't read, but I tend to learn from the chatting with others, looking at YouTube's, and the conventional learning is not for me. But no, if you go to when I go to meetings, or I interact with other surgeons, and that I found is one of the best ways of lively learning, with which I actually change my own practice. Whereas reading, no, I get knowledge, but how influential is it for the patient care? I feel it may be limited. Now, looking around my own neighbor, there are amazing surgeons around in the city of New York. So it didn't come from my own. No, we've all felt it's a good idea to get together and talk about aortic medicine. And that was enhanced during the COVID. And during the COVID, first of all, we didn't have anything else to do. No, we might have treated the COVID patients, but our usual passion on surgery, that energy had to go somewhere. So everybody was excited to get together and talk about aortic thing, and that was that turned out to become our first project. That was to look at the this to describe the situation of city's experience of type A aortic dissection and across the COVID time. And we found that type A surgery for type A dissection acutely dropped in New York City. And we published that in JACC. So no, I think we all, through that first project, surgeons enjoyed it and realized more that partnership and lively discussion, getting connected, are all useful. for us all.
Absolutely, and useful for us as students to see these papers and, and see your experiences. And speaking of students, much of our audience today are either aspiring cardiovascular surgeons or specialties and other specialties as well. We wonder, what advice would you have for us today on the call if we're interested in aortic disease management?
Mhm. Well, I don't feel that I have to give you advice because no, you guys are all high achievers. You guys have all your own motivations. So no, I'm happy to ask questions, but I don't feel I'm good enough to give you advices. Now, one thing that's been helpful for me is myself just following my own passion. No, I have done minimum the stuff that I didn't want to do. I've been doing almost always doing what I want to do. So I would suggest no, you do what you want to do. I'm sorry, I'm not helping you guys here. But for instance, look, no, at least I'm in New York and I'm looking at the backyard. The outside is fantastic. The weather is fantastic. Um, this is one of the probably the best weekend we could have. Now, why am I sitting here and talking to you guys? Then why did I spend morning with Chris and others talking about research? That's my choice. That's because I love it. I'm happy to sacrifice this weather to talk about aorta. You should choose what you want, what you are this job, your job, whether it's heart surgeon, aortic surgeon, or whatever it is, cardiologist, ophthalmologist. It has its own intensity. But if you feel passionate, it's a joy.
Certainly is. And thank you so much again for sharing your morning with us. We do want to be respectful of your time. Maybe you can catch some of the weather after this. But uh, if we have any questions from our audience, I'd like to open it to them. Or if you have any closing remarks, Dr. Takayama. This has been very, very helpful for all of us. And I think to our patients listening too, we really appreciate you and other surgeons coming and sharing your expertise with us and inspirations for the field. If we don't have any closing questions, I think we can end the live and post this online and hopefully distribute it to our student listeners.
Yeah,
Thank
I
you.
actually have a question, Dr. Takayama, if you don't mind taking some more time out of your day.
No. I can spend another 3 hours if you want.
I think for us as we are entering the field, kind of like understanding where the direction the field is heading, kind of where maybe our careers may head, is definitely an interest for us. And I think one thing that within our lifespan, a lot of us have seen is the rise of like endovascular techniques and minimally invasive techniques in cardiac surgery. And as an expert, I wanted to hear your opinion on where do you think the field is heading, or aortic surgery in general, with endovascular approaches?
Excellent question. No, there's no doubt that endovascular therapy is becoming more relevant, and we should all invest on exploring the pathway. It will only get better, and it will only help our patients. So in that sense, no, even now, contemporary aortic surgeon should be able to handle both open and endo procedures. I will no ask you the question though, no, which I asked many of my residents. You guys are all smart and smart enough that to the point where Chris, you knew the answer. Now, no, when but for instance, TAVR versus SAVR, we all know that TAVR is becoming the mainstay of aortic management of the aortic valve. And TAVR is an excellent therapy. No, I will send my own patient to TAVR instead of SAVR. No question here though. does it become, you know, it's one thing to recognize and understand the future and direction of therapy, but it's another thing for our own individual to decide and choose what you want to do. I'm saying this because I ask to every single patient, no patients, maybe they are patients, residents of mine, why do they want to be a hybrid surgeon, incorporating transcatheter therapy and open surgery? Why I pushed even some of them to consider, wouldn't they consider becoming a transcatheter surgeon, primarily doing a transcatheter therapy? All of them, zero exception, all of the residents said that transcatheter therapy is just not what they want to do. They want to do an open surgery. So here, no, let's face it. No, I'm sure many of you are primarily interested in open procedures. And I can reassure you that open procedure will always be needed, always. However, it'll be likely less number of open surgeons are needed, so no, than before. Even now, though, it is difficult to understand, do we have an appropriate number of open surgeons or not? It is unknown. Some of the expert of that kind of analysis says, even now, we need more open surgeons, or in other words, conventional heart surgeons where we do open surgeries with the population aging. But is it so? And you are becoming my age, so that's like a couple of years from now, sorry, maybe a couple of decades from now, and that's an open question. No, like you might have heard, I would say open surgeons are always needed. And no, if your passion is to become an open surgeon, become an excellent open surgeon, because excellent surgeon will always be needed for sure.
Thank you very much.
Do we have any other questions from our audience members? All right. Well, Dr. Takayama, thank you very much again for sharing your morning with us. And we're very excited to see where the field continues to take us, especially as with all these upcoming genetic and endovascular advances coming. Thank you again, and thank you to all our tuners for coming in today. Have a wonderful evening, everyone. Wonderful morning. It's not evening. Take care.
Thank you very much. Have a good day.
Bye.
Thank you.